Today I'm going to talk about the clinical and registry entry, a semantic model meant to represent patient-based registry information. The motivation about the creation of that semantic model was also discussed by Anna a few minutes ago, which is the increase of the number of registries, the lack of interoperability and fragmentation that these kind of registry have today. So research spend too much time filtering, pre-processing the information. So we, from the EJPRD perspective, we detected the need of creation of a semantic data model that it was capable to perform federated analysis and exploration. This road started 5 years ago in the EJP with the creation of a semantic data model that probably some of you all know, which is the common data element semantic model. This model was meant to represent a very concrete set of data elements provided by the European Commission, and the creation of these 7 instances that relates the scaffold of the representation of these semantic of these data elements was created that contains the information about the patient identifier related with a role. This role is followed by a clinical process that has as an output an entity, and this is referred to a personal attribute from this patient. The need of expanding this very concrete set of data elements to cover not just those, but also any data entry that can be part of a data registry led to the creation of what we know now as the CDE-SM model. The CDE-SM model have been expanded with way more instances that are capable not to represent those, but even more representations. This is how the model looks like now. The model is based as a scaffold on an upper class domain ontology named semantic size integrated ontology, SIO. This ontology allows us to represent every entity and its relationship, which is part of the model in the upper class definition. Like, for example, what the process is, what an attribute, and what an identifier is inside of the model. At the same time, on top of that, we use all foundry information to enhance the domain-specific information. So we are defining at the same time what a process is and what, in case of, for example, a diagnosis, that this process is a diagnosis procedure. We have increased our consistency by the combination of both ontologies to represent each one of the instances that are part of the model. The model right now contains more information than the previous version, like, for example, agents that are connected to the process, targets that could be, for example, anatomical structure that are participant in the evaluation or the measurement, and also the last acquisition that was the creation of a protocol and several attributes that are related to this protocol. Like, for example, in case of a prescription, the process of the administration is associated with a protocol that contains information, like, for example, substance, route of administration, concentration, followed by its unit and frequency. I want to show you one example of how this representation will look like. This is a RDF representation that informs about the information of birth date. So as following the structure, we have the node that represents the process, followed by its output, which will be the formatted date, and it refers to a personal attribute, which is in that case the birth date. Same structure can be reused for other representation, like, for example, diagnosis. A diagnosis have a process, which in that case a diagnosis procedure, followed by its output could be observation result, and it refers to a personal attribute, which is the condition as a form of disease or diagnosis, annotated in a different ontology that could be, for example, human phenotype or ortho from Orphanet. Other representations that are new for the semantic model, which is, for example, the drug administration, that have a different instances, but all of them are defined in the main structure of the model. Like, for example, the use of medication, as I said before, that contains the drug ID, route of administration, the concentration followed by its unit, and the frequency of this dose defining the prescription. Another example will be, for example, the measurements of a laboratory procedure, where we have the input, which is the anatomical structure that we extract information, and the target will be the molecule targeting that targets the process itself, followed by its output defined by its unit. So as you can see, we are using those instances to define every data representation that we could find on those registries in a semantic way. One of the most important acquisitions that have defined the change of the CDE to CDE-SM was the creation, the use of RDF quads rather than just regular triplets that were used before. Why? Well, the fourth structure of the representation of a triplet allow us to create a common identifier for each one of the triplets that are defined inside of this data element. This allow us to connect this information to temporal data, like, for example, time intervals, starting date and end date, also age information, in case that you want to define the age of the observation that the patient age that have this patient in that moment. And this information allows us to create a timeline of events that creates an encounter structure for the representation of that data element. This information can be related to other data elements under a common event instance, followed by its event identifier. So we can define the information individually, but also we can create this encounter-based structure that enhance the capabilities of the semantic model to be used for example, hospital encounters definition. Those visits can be used by this event. The main objective of creating a semantic layer for patient data is the capability that these semantic web technologies have to be interoperable with other data, healthcare data standards. The consistency of this model gave us two main advantages. First of all, if we have a common structure, we can reuse the same templating process to obtain more efficient ways to populate this semantic model. And at the same time, if we use the same structure, we can reuse that structure for querying, so smarter agents can be created based on that structure, because small changes define a lot in the model. We are capable of creating a scaffold Sparkle structure that can be reusable for any data query process, exploration, and transformation. In order to enhance the capability of querying this semantic data model, we have created an API that is capable to obtain anonymized patient information by enhancing the capability that this queryability aspect have CDE-SM. So by the use of beacon interface, we have created a beacon API that takes the JSON structure definition of what filters do we want to use to identify and discover what data we have in our registry. This JSON structure is converted into a Sparkle due to its reusable structure, where we can define blocks of Sparkle structure that are aligned with any data entry that we have in our registry. So the fact that we have this Sparkle structure allow us to create those kind of interfaces, and it sends to the triple store where the information is, and it's retrieved anonymized output to make sure that no sensitive information is exposed. I wish also to mention that in order to be interoperable with other data standards, we are creating a ETL process and a structured transform low workflow that takes the information from a tuple store, and by using this structural common, this common structure of KRSN for any data entry, we can extract information via Sparkle and turn it into a OMOP compliant data table. This information is later injected in any PostgreSQL database that are compliant with OMOP CDE, CDM representation, like all the interfaces that ODC have. We are lack of time to explore the implementation, but today there's a demonstration about KRSM during the lunchtime. So if anyone is interested on how to populate KRSM or play around with the capabilities that this data model have in order to perform data querying, join us. We will be in the lunchtime during the demonstration, and we'll be very thankful for you to be there. I thank you so much for the EJP and all people that made the semantic model to a real semantic data model for the community, and thank you so much.
Hi.
Hi.
Ilke de Hive. Thanks for a nice presentation.
Thank you.
So yeah, it's a small question actually, but I encounter these things in my work as well. So for instance, for information content entity, I see that you use SIO a lot, but of course there's also the information artifact ontology and BFO. Are these things aligned, or I know that in the information artifact ontology there's information also a similar entity. How do you make the choice, or between which one to use? I know that the IAO has a lot of reuse, or is a lot extended by other OBO ontologies.
Thank you for the question. It's a really hard question to respond in that time, because it's a really interesting conversation that semantics have to what ontology we pick in order to make the representation. We selected semanticized ontology due to its capability to represent these upper classes terms, but in order not to include too many multi-classing in each one of the instances, we decided to pick this one just because of to be consistent in terms of reducing the amount of terms that we use to use just one for the upper classes and one for the domain. SIO is a great ontology for representing this kind of class, upper class domain, but we decided to pick this one because its capability, but even though the other one could be also use it for this kind of same processes. But we had to take a decision at the very first moment, and we decided to pick semantic size ontology because those capabilities. But we could explore the idea of being capable of represent the same information also using other upper classes ontology like that one. Yeah, thank you.
Maybe I can actually comment on that as well. So it's one is that sort of taking a slightly higher level view of it in a rare disease community, we cannot afford to be compatible with only one model. We know that, right? We're among all sorts of other data that use other standards. So you saw already mapping to OMOP as an example. I think even in our team for our own hospital, Nuria, right? You did a mapping to exactly the OBO Foundry ontologies, and that's fairly straightforward to do, right, Nuria, to make that transition from the core model to that. And so that's a given that we need to make those mappings. It is some extra work. It's also, sort of what you want to at first create a model in, but we're not saying this is the only thing you can ever use outside of it. It's just that we need to do the mappings then.